Good morning, everyone. Thank you so much for joining us. I see we already have about 35 people logged in. That's great. We are just going to go ahead and jump in because we know everyone has a lot of stuff to do and everyone's time is really valuable. And we do have a lot of information to present in this 90 minutes. So just to introduce myself, I'm Kara Skillingstead, and together Mandy Altman and I run the National Hepatitis Corrections Network. For those of you who are not familiar with the Corrections Network, the NHCN is a network of people who have an interest in viral hepatitis and corrections. So our professional network is really diverse. We have lots of partners across the country, and includes correctional health administrators, healthcare providers, researchers, legal and policy stakeholders, community-based organizers, and educators. And the Hepatitis Education Project is what manages the National Hepatitis Corrections Network. So HEP is a nonprofit organization that's based in Seattle, Washington. The primary role of the NHCN is to track broad trends in viral hepatitis in the correctional setting and share best practices, research, and resources with our network, as well as people experiencing incarceration and their families. So in order to address hepatitis A and the current outbreaks across the United States, it's critical to focus on correctional populations. So today's webinar is designed to deliver recommendations for addressing hepatitis A in the correctional setting, explore strategies and steps in different correctional settings, for example, jail versus prison, prevention versus intervention. We're also going to present some practical steps and suggestions for replication in other regions. And we will provide a forum for professionals to ask questions, share successes, and overcome challenges. So our webinar today is going to be 90 minutes, and we'll feature 4 presentations that include an overview of hepatitis A outbreaks from 2016 till now and the impact it's had on correctional populations. We're going to hear from somebody in the Ohio State prison system talking about addressing a hepatitis A outbreak in the prisons. We will also have a presentation by somebody from the State Department of Health in Indiana, who's going to talk about hepatitis A outbreak in the jail population. And then we'll hear from 2 of our members from the Knox County Health Department in Tennessee talk about vaccinations in a jail population. And then at the end of the webinar, we're going to have a 25-minute question and answer portion. So if you do have questions throughout the webinar, there's a tab on the right hand of your screen that says questions. Feel free to type in any questions you have throughout the webinar, and we will collect them and host a little quick Q&A at the end. Before we get started, we have a quick poll that we want to do. If you all could, on the right side of your screen under the polls tab, see that there are different types of agencies described there. If everyone could sort of chime in with what type of agency they work with, it'd be great to know who is in the webinar today. And then feel free to select more than one option if you think that there's not a full encompassing in one category or another. But just while we wait for everyone to respond, on the screen right now, we have the list of our presenters. So we have Martha Montgomery from the CDC. We have Kevin Runyon from the Ohio Department of Rehabilitation and Correction. We have Nicole Stone from the Indiana State Department of Health. And then from the Knox County Health Department, we have Jane Crow and Gary Howes. So without further ado, I'm going to have our first presenter, Martha Montgomery, begin with a presentation from the CDC. Thank you, Martha.
Great, thank you so much. Is it switching slides? All right. So thanks so much for the opportunity to present. Today I'll be discussing the hepatitis A outbreaks from 2016 to present. I'll start off with an overview of hepatitis A. Hepatitis A infection is caused by a virus that replicates in the liver. The hepatitis A virus is hardy and can live on surfaces for months. Hepatitis A causes an acute infection. Most adults develop symptoms that include fever, jaundice, fatigue, vomiting, diarrhea, and abdominal pain. Symptoms can last from weeks to months, but it does not develop into chronic infection like hepatitis B or C. The average time from exposure to symptoms is around 28 days, but it can range anywhere from 15 days to 50 days. The disease spreads through the fecal-oral route. This usually means it spreads through close personal contact with an infected individual, and less often this occurs through consumption of contaminated food. Once a person is infected, they can transmit infection to other people anywhere from 2 weeks before they develop symptoms to 1 week after jaundice. The good news about hepatitis A is that there is a safe and effective vaccine available, and hepatitis A immunization has been a public health success. The hepatitis A vaccine was introduced in 1996. It is given in a 2-dose regimen with a second dose 6 months apart. But even giving the first dose alone can provide protection for up to 11 years in healthy individuals. The Advisory Committee on Immunization Practices has recommended universal childhood vaccination for hepatitis A since 2006. In addition to recommendations for children, they also have recommendations for specific adult populations, including users of injection and non-injection drugs, men who have sex with men, and as of this year, people experiencing homelessness. In the figure, you can see that the US has experienced cyclic national increases in hepatitis A, but after the introduction of vaccine in 1996, there was over 95% decrease in reported hepatitis A infections. Unfortunately, in the last 3 years, we have seen an unprecedented increase in hepatitis A. This figure shows the number of hepatitis A infections reported each week through our National Notifiable Disease Surveillance System. The light shaded pink area indicates cases reported during the period where we expect some reporting lag to occur. The red bar indicates the weekly threshold for when we consider an outbreak. In 2018, you can see the cases really took off and continue to remain far above the threshold even today. Nationally, 30 states have reported hepatitis A outbreaks since 2016. This encompasses over 27,000 outbreak-related hepatitis A cases. Around 60% of people in the outbreaks have been hospitalized, and 275 deaths have been reported. This map shows the states that have declared hepatitis A outbreaks. 2 states, California and Utah in gray, have declared an end to their outbreaks. Certain populations are at higher risk for hepatitis A infection, and this includes people who use drugs, people experiencing homelessness, and men who have sex with men. I want to emphasize here that the risk related to drug use is not unique to injection drug use. People who use non-injection drugs are also at increased risk of hepatitis A infection. One important aspect to note about these outbreaks is that the hepatitis A infections have been more severe than normally reported. As I mentioned, the hospitalization rate during these outbreaks has been around 60%. In the past, outbreaks were driven in part by asymptomatic young children. Illness in young children tends to be less severe if they develop symptoms at all. Since the universal childhood vaccination recommendation, hepatitis A cases now are mainly among adults who are more likely to be symptomatic and develop severe infections. In addition, because of the overlap with drug use, we are seeing high rates of hepatitis B and hepatitis C co-infections. Hepatitis A infection in someone who already has liver disease from hepatitis C increases the chances of hospitalization, fulminant liver failure, and death. It has been estimated that the healthcare costs for these outbreaks are over $200 million, and we believe that this is likely a conservative estimate. So where do we see the intersection of these hepatitis A outbreaks and incarceration? We know that people who are incarcerated have overlapping risk factors with hepatitis A risk groups. The Bureau of Justice Statistics estimated that around 80% of prisoners and jail inmates have ever used any drug in their lifetime, and around 70% regularly used any drug prior to incarceration. We also know that homelessness is overrepresented in incarcerated populations compared to the general population. Another consideration is the risk for hepatitis A transmission both within and between facilities. People are living in congregate settings and using shared hygiene facilities. Both of these can increase the risk of hepatitis A transmission. In addition, there is high turnover between corrections and the community, so when an outbreak occurs in a community, it can easily spread to corrections and vice versa. And to complicate matters further, there are transfers of inmates among different facilities. If you recall, I mentioned at the beginning that people with hepatitis A infection can transmit infection to others up to 2 weeks before developing symptoms. So you can see how complicated these outbreaks become. In terms of the current hepatitis A outbreaks, we have some reports of hepatitis A cases among people who report recent or current incarceration. These are data from 7 states that report incarceration numbers on their outbreak websites. The full bar shows the total number of hepatitis A outbreak cases, and the section shaded red shows cases among people who report current or recent incarceration. You can see that the proportion is variable anywhere from 7% of all outbreak cases in Michigan to up to half of all cases in Alabama. So hopefully by now I've convinced you that hepatitis A is on the rise and that we're seeing cases among people who are incarcerated. So next, I'd like to talk about what the accompanying response looks like. And the main take-home point, if you stop paying attention after this, is this: that the hepatitis A vaccine is the best way to prevent hepatitis A virus infection. There are a couple of points where public health and corrections interact during these outbreaks. The first and most obvious is when a case of hepatitis A is diagnosed during incarceration. When a case of hepatitis A gets reported to the health department, it sets off a series of events and an investigation. Health departments interview patients who are diagnosed with hepatitis A, not only so that they can report the case to CDC, since it is a nationally notifiable disease, but also because there's a small window of opportunity to prevent infections from occurring in people who have been exposed. This work can be challenging in the best of circumstances, but in a correctional setting, it can be even more so. This presents opportunities for collaboration between public health and corrections. Corrections can be helpful to public health in facilitating case interviews, in gathering risk factor information, and in gathering various dates like dates of intake, transfer, and symptom onset. And then, as I mentioned, there might also be an opportunity to provide post-exposure prophylaxis to staff and other inmates who are exposed to prevent infection from spreading. Your state or local health department can be a great resource if you have questions about how to administer post-exposure prophylaxis in these settings. What health departments have found, however, is that post-exposure prophylaxis alone may not effectively control outbreaks. Instead, health departments have focused on primary prevention with vaccination of high-risk groups. This has involved a lot of creative solutions to deliver and administer a vaccine to high-risk groups in a variety of different venues. One of the most effective venues is correctional settings. The strategy of administering hepatitis A vaccine in correctional settings in the context of an outbreak is not a new concept. This article by Vong and colleagues discusses vaccination in the county jail as a strategy to reach high-risk adults during a community-based hepatitis A outbreak among methamphetamine drug users. If you didn't know any better, you might think this was an article that was just recently published, but in fact, this article was published over a decade ago after a community outbreak in Polk County, Florida during 2001 to 2002. What the authors found, and I think a lot of public health departments today really identify with this quote, is that the county jail made a unique vaccination venue because the setting was able to concentrate in a short period a large number of persons who would benefit from vaccination and usually be difficult to reach. If you're considering hepatitis A vaccination in a correctional setting, here are a few tips that can be helpful to consider. First, pre-vaccination serologic testing is not required to administer hepatitis A vaccine. Second, vaccinations should not be postponed if vaccination history cannot be obtained. However, one strategy that has been successful is for the correctional facility to provide the health department with a list of inmates so that the health department can cross-reference this list with their immunization registry and identify people who don't have a documented hepatitis A vaccine dose. And then lastly, health departments and correctional facilities have learned that repeated attempts might be necessary to improve vaccine update. Don't be discouraged if on your first attempt the vaccine uptake is low. Sometimes it takes 4 or 5 visits before people start agreeing to vaccination. And then lastly, I'd like to take a couple of minutes to mention some of the hepatitis A outbreak materials that we've developed in response to these outbreaks. The first is the Hepatitis A Outbreak Response Plan. This was designed primarily for state and local health departments to investigate, monitor, and respond to person-to-person hepatitis A outbreaks. This document is a compilation of best practices learned from experiences of local, state, and federal public health agencies. It was really designed to be a how-to guide on developing a targeted vaccination strategy, mobilizing resources, and establishing a data monitoring plan. There's also a plethora of outbreak communication and education materials that have been developed for public and professional audiences. This includes our website, where you can find information on the latest case counts and affected states, as well as fact sheets, posters, and pocket cards. We have versions in both English and Spanish. There are also materials that have been tailored to specific audiences, including people who use drugs, people experiencing homelessness, and gay or bisexual men. And then lastly, I wanted to share our vaccine hesitancy guide, which was developed to help vaccinators encountering clients hesitating to get vaccinated against hepatitis A. It includes 6 main content areas, including information on basic knowledge, perceptions of risk, symptoms and perception of severity, vaccine concerns, cognitive barriers, and post-exposure prophylaxis. It is designed with examples of client statements paired with potential responses to those concerns. This document was developed with input from field staff. We've learned a lot of practical knowledge from our local and state partners who are doing this work. Simple adjustments to how you frame the question can alter vaccine acceptance. For example, asking someone, do you want a hepatitis A vaccine, will get a much different response than if you provide some context of the outbreak and the risks and benefits, and then ask, which arm would you like the vaccine in? So in summary, community outbreaks of hepatitis A virus infection have been prolonged and challenging to control. Outbreaks are primarily affecting vulnerable populations, including people who are incarcerated. Morbidities have been higher than previously described. And lastly, vaccination is the cornerstone for control of community person-to-person outbreaks. So thank you. And if you have any questions, you can always reach out to one of our team members at any time at viralhepatitisoutbreak@cdc.gov. Thanks.
Thank you so much, Martha. Again, if you do have any questions about any of the presentations, feel free to type them into the questions tab on the right, and we will collect them for the question and answer portion at the end. And now we're going to hear from Kevin Runyon from the Ohio Department of Rehabilitation and Correction. Here you are, Kevin.
Greetings, everybody from Ohio. Run through my presentation here. Is it loading up on your side? There we go. All right, so as I said before, I'm Kevin Runyon, the Medical Operations Director for the Department of Rehabilitation and Corrections, and I used to be the infection. Hold on, I'm getting feedback on my end. So I used to be the infection control manager, but took a role promotion. Now I'm both. So moving forward. So we have a big hepatitis A statewide outbreak here in Ohio, and our state health department and local health department partners have been really responding to it, very much like Martha said. And there's no doubt that it really has put a serious weight on the shoulders of those individuals as they're moving forward and taking care of the community at large. You can see just for the numbers in Ohio alone, and this is updated as of October 28th, we had 3,363 cases from when the outbreak was originally started or called, and then you can see the ages, the percentages, and the hospitalizations. In particular, this particular hepatitis A virus seems to be really, really strong and put a lot of folks in the hospital here. If you see the map of Ohio, you can see the dark green is the areas where we have the largest amount of cases, and those usually correspond with the larger cities in Ohio, Cleveland, Columbus, Cincinnati, Dayton. But a lot of those other areas with the green are some of the areas that we see a lot of our drug abuse individuals coming on. Those are smaller areas, depressed areas economically. And we really saw an uptake in cases there that really corresponded with a lot of the drug abuse and the individuals that were being incarcerated. It's important when we look at this slide that remember that when we come back and talk about where our prisons are located at and talk about county jails. So in the state of Ohio, we have 28 prisons across the state. As you can see where they're in the white little bubbles. We have a centrally located office that controls all medical operations, and in each institution it has fully staffed with medical staff, nurses 24 hours a day, and a chief medical officer. And areas that in particular are, you'll see that just in the middle of the screen is CRC, is one of our reception centers, and that's important to know. And then up north we have LORCI, which is another one of our reception centers for males. That'll be important as we move forward with our issues. So the slide there, you can see the jail overcrowding. Actually, it's supposed to be animated. I don't think it works in here in particular, but it's county jails have a cycle of overcrowding here in the state of Ohio. Basically, there's a lot of individuals inside those jails. A lot of times there may not be enough beds for everybody. Some folks may be on mattresses on the floor, and it's constantly cycling and cycling. And you have individuals that may be in there while they're being incarcerated until their court dates are over, can be there for 6 months to a year. And you have individuals that are moving in and out of those pods or dorms, for maybe just the weekend. And if you can imagine the folks that are being exposed to this virus out on the street, come into the facility, they're sharing common areas, shower facilities, restrooms in particular, and have with the folks that are being kept over and being charged with felonies and then actually ending up in prison, there's a lot of chances for exposure there. So usually if an individual was going to come to prison in the state of Ohio, they would be held in the jail for a minimum of 3 months while they're going through the whole process of being convicted. And you would think that that would stop them from coming into our prison with the actual infection. Well, unfortunately, because the exposures in county jails, that's where we saw a lot of our cases jumping off at. So hepatitis A is a reception nightmare. The timeline associated with hepatitis A infection usually it's hard to make an early diagnosis, so it makes it very hard to stop the spread, and it makes it extremely difficult. The transient nature of our population makes infection control almost impossible. And so let's review the hepatitis A infection timeline. Actually, this thing here, this slide didn't come out correctly, but you'll see the average stay at reception for the Department of Corrections is usually about 8 weeks. And unfortunately, my slide would show you the exposure period, the time frames in which individuals actually have when they actually show actual signs and symptoms, usually can come up to 50 days afterwards. And you can see where, during that time frame, you may not know somebody actually has the signs and symptoms of hepatitis A. So it takes a lot for our staff to be on very vigilant as what's going on. And then also it makes it very hard to use just the testing. And we actually tried that. We tested everybody coming into our facility for hepatitis A on intake. And unfortunately, those markers didn't show up immediately. We had cases that would become positive, we would find to be positive later. So that was, if you're thinking about that as your end all be all, that doesn't work. And our state health department corrected us very quickly on doing that. So tracking the cases, obviously, if you've done anything with tracking outbreaks and line list, we got our line list. We determined the county of origin, which those individuals are coming in, because if we had new cases, we want to let that county know that somebody had come in that had the signs and symptoms prior to that 50 days before. And we tracked where they came in at, the housing unit which they came to us, and where they were housed 14 days prior and 50 days prior. And we would track back to determine who our possible exposures were and where the actual infection started at. And that would help us control with our control efforts and then communication to other individuals. Like I said, the Corrections Reception Center, which is that reception center in the middle of Ohio, covers 2/3 of the state. Those were primarily where all our cases came in at, and for the counties that fed that. Some of the problems we had with testing is our docs would test for the hepatitis A antibodies, the IgM and the IgG. If those were positive, they would think that those individuals who were past positives or had been vaccinated and let them slip through our net. The test that we used when if anybody came back hepatitis A, IgM acute, those were folks that we considered positive, and we put those into isolation and start our infection control activities based on that. So it took us a long time to kind of train our staff that if they're going to run one test, they needed to run the other, and to rule out any kind of recent infection. And that became a very big challenge for us. So once we did that, we determined a case was actually positive, we would stop the movement in the infected dorms for a period of 14 days, and then we would vaccinate all those individuals that were in that dorm or that close that would be used in common areas, the restrooms in particular, and we would do the vaccination. Now, we didn't test for if they'd been vaccinated before or not, unless we had that information readily available. We went ahead and vaccinated everybody. We didn't let bed moves inside or out of there. We didn't let them go to halfway houses. No transfer to the other institutions. We didn't let them transfer outside of that dorm. So we evaluated all individuals in that dorm for signs and symptoms of infection. And then we vaccinated the other folks that weren't inside that dorm, such as food service workers or maintenance workers or medical porters. We offered vaccine to all our staffs that had concerns. So, and that's really, really big. We'll talk about that here in a minute as far as your communication plan. But if you don't have folks that are comfortable coming to work or concerned about getting hepatitis, that's a real big challenge for you. So we went ahead and opened up the doors for vaccine for those folks. And then as this outbreak continued, we started, that became a available vaccine for our staff, period. We've set up vaccine clinics for them. We've given vouchers to go to CVS to get vaccinated for hepatitis A to make sure all our staff are covered. We did an inmate education. We did sessions inside the dorm where we brought everybody around to let them know what was going on, make sure they understood how the virus was spread, answered questions. That was a big deal to make sure that everybody was comfortable in there as well. We provided proper hygiene materials and cleaning supplies for the dorms, and that's something you might want to go out and check out during any kind of outbreak. A lot of times, some of the first cutbacks that come for in a facility is paper towels and soap to wash hands. So that's one thing we made sure that all that stuff was available, and that somebody was actually kind of doing gentle reminders to folks in there. Wash your hands, wash your hands. We used control the ice machines or microwaves. We assigned porters to actually get the ice out and to clean those microwaves between uses. You know, that's a spot right there that we had opportunities for that fecal oral, that hand to mouth type kind of exposure. So we really locked that down. And then we increased the surveillance of disease and access to medical for suspected cases. So if somebody had any kind of the concerns or the signs and symptoms, we said, go ahead and bring them on up. A lot of times there would be a challenge with that in the past, you know, maybe make them sign up for sick call, but that was one where we told folks, don't turn anybody away at the door or any of those phone calls coming from the officers. And of course, any of our suspect cases were isolated until we could get a negative Hep A antibody. Oops. So in isolation, we use the enteric precautions. Challenges related to an outbreak like that is we run out of infirmary space very, very quickly. So we would identify additional dorms or areas where we had single cells, where they would have a single cell with the restroom abilities in there, and then making sure folks kept them in for until make sure we are cleared of the disease and the abilities to pass it along. So back to the communication plan. It's really, really important if you want to succeed in a correctional environment is that you have a good communication plan. And I know there's probably a lot of folks out there shaking their head right now when we talk about concerns. And a lot of times it's not so much your incarcerated population, but your staff that really gets concerned and has a lot of starts talking and have issues, and it can be very difficult to quell their fears. So when you bring your team together, you want to make sure you've got your medical, your custody, your administration, and then in the state of Ohio, we have bargaining unions. We had union folks come to that and develop that plan together. So when everybody leaves that room, they can go out and teach that plan to everybody and sell that plan. And that really, really helps to make sure folks know that, you know, administration's just not doing anything to save money or something like that. They're meant to be doing the right thing, and they're concerned. And that's that develop united message, and then formulated communication plan for both staff and inmates. Staff communications, we did flyers, we gave those out in roll call. We spoke to the union reps both at the institution and at our statewide level, and make sure that they were sharing the information. It was all the same message, and we were using good resources like the CDC or the state health department. We made sure we tried to get folks away from going to Men's Health Journal or GQ for any of their information. Inmate communication, we have a JPay system here in Ohio. They had the kiosks, we could push information out. Of course, we had the open houses where we spoke to folks, and then they also had the JPay tablets. So we were pushing messages out constantly and making sure when we had those opportunities to reach out and talk to those folks that we, you know, were teaching that same message, especially about hygiene. Environmental controls, like I said before, we really upped our porters and our abilities to do cleaning, like taking care of those microwaves, making sure that ice machine, there wasn't a bunch of folks reaching in there with their contaminated hands or touching that same scoop. And of course, real big emphasis on cleaning the latrines. Vaccinations, we had to determine when to vaccinate, who to vaccinate, and how to get the vaccinations. Vaccine source, we had our own pharmacy provider. It's more expensive. There's flexible movement between that and the facilities as they were necessary. And then the Ohio Department of Health, they came to our rescue on a lot of these cases. They provided free vaccines. There's a demographic data exchange, and anybody that's ever worked with public health knows that they want some information and how you're dispensing and using their stuff. So, that's a little bit of a challenge, but it's worth it. We were very thankful for their assistance. So inclusion criteria, so like I said, the threats we were looking at for folks that were coming in that were not cases, but we would vaccinate upon admission would be folks with that homeless background or had used drugs in the past 6 months. We went ahead and offered them vaccinations. Our challenges were the refusals, as the presenter before had said, and then a lot of times folks would be in the jails for 6 months or greater. And then this series of vaccines, you need to track it and make sure you continue on with the vaccine process. Prophylactic vaccines, we had basically all those folks that were in those dorms that we had identified earlier that had shared with the folks that had the actual infections. We vaccinated all those folks, and I'm talking, we were probably close to 3,000 vaccines across our state. By the time we were done with most of our cases, hopefully forever we're done, but you never know, knock on wood. But anyways, we gave the one-time prophylactic vaccine, and we cast a very, very wide net. We used the dorms instead of a ring vaccination. There was a lot of debate between us and public health and what we should do. And we said, basically, if they're going to have an opportunity to be exposed to the latrine facilities, those are the folks, if they're sharing those living areas that close, we're going to go ahead and vaccinate them. It was a big challenge because based on all the communal areas. Public health response, once again, it was working closely with these guys was amazing. They provided the vaccines. Local health departments vaccinated in several of the large jails. So we, being the largest correctional facilities or in the state, we helped to communicate with the locals in the county jails on how to facilitate entrance into there, working with the sheriff's office. Ohio is a home rule state, which means the jails are governed by county commissioners. There's no centralized system to help with control infection. So we basically would work with the jails and say, hey, this is the right thing. We can help you get some free vaccines, working through the health departments and help them get buy-in to do some vaccines there where the biggest chance for spread were. What we had to do after this or during this was to create protocols for the prevention and treatment of hepatitis A. And basically that would be to educate our staff on transmission, explain the natural history, develop reception screening intake processes, provide diagnosis criteria, dictated disease treatment, education on disease prevention, and set parameters for environmental precautions and infection control. We have tons of protocols and policies across there, but they weren't specific to hepatitis A. Our new hepatitis A protocol was born out of this. So after the written, you have to get really, really busy on making sure that you educate. And a lot of times, a lot of folks don't care about a particular disease when it's infectious until it happens in their facility. So trying to get that information out quick and tell folks they got to pay attention. This can be a concern. This could be coming to your facility. That was very, very hard. So we had a statewide medical leadership meeting where we brought all our medical leaders in. We had monthly video conferences, emails, and posted to our internet page. And then we had a post-test written for the policy and protocol. So each time we roll out a new protocol, there's an actual post-test that all medical staff have to take, and they have to track that inside the institution, make sure everybody understands the new protocol and how it works. And that's real. Our healthcare administrators track that, and then we keep all our percentages of that and see what we do. So they have to pass a percentage of greater than 80%. Our quality improvement coordinators track this, and then our RNAs, the folks that are on my team, go out there actually and check to make sure all the staff are that and do some spot checks on education. So basically, if you know anything about the Department of Corrections or working in a prison system, it's basically on to the next fire after something like this happens. And it's really, really hard to keep people focused on, hey, hepatitis A is still out there. We didn't stop it. That outbreak's still continuing and stuff. And corrections is ever changing, so you can't count on the same people to be there that knew this message about hepatitis A that were there 6 months. We've turnover of our staff, turnover inmate population understands that. So we constantly have to reinforce this that, hey, be aware, be on the lookout for hepatitis A, in particular our reception areas. And that's the last of my presentation.
Thank you so much, Kevin. It was very illuminating. I love your use of graphics. So next up, we're going to have a presentation by Nicole Stone. She works at the Indiana State Department of Health.
All right, thank you. Thanks for having me on the call today. So my name is Nicole Stone. I'm the foodborne and waterborne disease epidemiologist for the Indiana State Department of Health. And for the past almost 2 years, I have been the lead epidemiologist for our hepatitis A outbreak in Indiana. So I'm first going to just go over kind of an initial example in some local jails here in Indiana, and then expand upon what ISDH has done, or the state of Indiana has done in response to cases and prevention in jail settings. So you can see back in 2017, this was our trend before the outbreak began in Indiana. We had a slight downward trend from 2013 to 2017. We averaged about 20 cases a year until the large outbreak was identified at the end of 2017. And the morbidity of hepatitis A in Indiana 2017 was 0.31 per 100,000. So on December 20th, 2017, a case of hepatitis A was identified by a local health department in the county's jail, Jail A, and reported to the Indiana State Department. The individual had recently transferred to Jail A from a local jail in Kentucky where a known person-to-person outbreak was ongoing. On January 10th, 2018, a case of hepatitis A was identified in a neighboring county jail, Jail B. This case had also recently transferred to Jail B from a local jail in Kentucky where a known person-to-person outbreak was ongoing, and there was no known connection between these two jail offenders. So there were two index cases of hepatitis A identified in Jail A, followed by 5 secondary confirmed and suspect cases. In Jail B, there was just one confirmed case identified with no secondary cases. An outbreak case was defined using the 2012 CDC and CSTE definition of acute hepatitis A infection, as well as requiring an epidemiological link to the original jail case or to an outbreak ongoing in Jefferson County, Kentucky. This is the very beginning of our outbreak in Indiana, so we did not have we had not declared an outbreak in our state at that time. The ISTH assessed infection control practices in Jail A and reviewed evidence-based best practices with the local health department and jail staff. The ISTH sent a questionnaire to be used for all jail inmates to record case information, requested active surveillance for additional ill individuals, and sent disinfection and isolation recommendations. The ISTH obtained a line list and positive lab results for suspected cases linked to the index case in Jail A. The number of exposed inmates requiring post-exposure prophylaxis was identified in Jail A, and PEP was administered. Assessment findings indicated that Jail A did not follow all of the best practices for responding to hepatitis A in the jail setting. In Jail B, identified case 2 upon intake as symptomatic and immediately isolated that individual. For Jail B, the ISTH also assessed infection control practices and reviewed evidence-based best practices with the local health department and jail staff. Active surveillance, isolation, and disinfection procedures were provided for this response, and the jail proactively purchased a vaccine for all inmates and jail staff, even though there were few individuals that had close contact with the case. In this instance, the jail staff followed the best practices and were proactive in their response to exposure in the jail. And did want to mention that this was before we were doing a lot of proactive recommendations and notifications to jails in our state. So this was all completed without kind of that background awareness. The differences between the two local jail responses was reviewed to determine how to best assist local health departments and jails for future situations of infectious illness in this setting, particularly hepatitis A, as we suspected we would be on the cusp of an outbreak in our state. Jail A was known to require offenders to purchase soap and had minimal hand identification procedures to prevent the spread of communicable diseases. Jail A was initially hesitant to work with the local health department and was slow to recognize the potential for quick person-to-person spread of hepatitis A among inmates, even with ISDH and local health department guidance. So things that were kind of discussed in the last presentation. This led to a delay in all response activities, including isolating ill individuals, testing suspect cases, disinfecting dorm and bathroom areas, and also for PEP immunizations. Alternatively, Jail B was described as a religious experience wherein the sheriff and jail staff regularly invested in the offenders' lives while in the jail system, not just for health, but also for social, mental, other aspects of their lives. The leadership's interest in Jail B and initiative in recognizing and responding to a case of hepatitis A ensured that they did not have any secondary cases. After 2 initial jail-based responses to hepatitis A, the ISDH quickly had to strengthen best practice messaging for preventing and responding to cases of hepatitis A in local county jails. The ISDH sent multiple notifications to jails and sheriffs requesting active screening for new cases. Early on, the education of offenders and jail staff was identified as a key component to understanding the importance of quickly identifying and responding to cases of hepatitis A. A best practice document for hepatitis A in jail settings was created to ensure future outbreak responses follow the best protocol. Many subsequent hepatitis A cases in other local Indiana jails have followed best practices and have not experienced hepatitis A outbreaks within the jail itself to varying degrees. Vaccination of inmates and in local jails was identified as a priority for prevention of hepatitis A in Indiana. So that's just kind of an example of what spurred our outbreak in Indiana, and it was related to transmission, both like what was mentioned before, outside of jails related to jail transfers, as well as inside jails due to the conditions that make hepatitis A very easy to spread in that setting. So here's where we are after 2017. So you can see our downward trend. It's a very tiny little bar now, and we've greatly added to our case counts per year due to our outbreak. You can see 2018 over 950 cases and over 1,000 cases so far in 2019. This is obviously preliminary data. So after that case and as those situations and as we saw increase in cases, we had begun active surveillance for hepatitis A in August of 2017 in Indiana, and then pretty quickly identified outbreak-related cases in December of 2017, originally linked to Jefferson County, Kentucky. After those initial responses, there's been an increase in cases statewide, although many counties are now post-outbreak, which we are very glad to see. We've had at least 78 out of 92 counties with at least one outbreak-related case, and at least 38 counties with a jail-associated case. This does include people who are either identified in a jail with their hepatitis A or who had been in a jail within their exposure period if they had already been released from jail. And then many of our cases, really most of our cases meet the risk factors known for the hepatitis A outbreak across the nation, including people experiencing homelessness, illicit drug use, having exposure to a jail, and then contact with an ill individual. This just shows our updated case counts as of October 25th. You can see we've had over 2,000 cases. We've confirmed 4 outbreak-related deaths and have over 55% of our cases who've been identified as being hospitalized. There's a lot of information on this slide, but I just wanted to show some of the specific demographic breakdowns for our outbreak. You can see 15% are known to be correctional facility inmates, again, either while they were in the facility became symptomatic or became symptomatic soon after being released from a local jail or prison setting. And this information is all available on our hepatitis A outbreak website. So what have we been doing in Indiana for immunization efforts? So we've implemented multiple approaches to protect people in Indiana since January 1st of 2018. We've conducted, as well as local health departments, don't want to take all the credit here. Most of this work is done at the local level as well. So we have a ton of post-exposure prophylaxis of close or household contacts for positive cases. We've had a lot of preventive outbreak responses in counties that either have had a large number of cases or who have been identified as having a high potential for hepatitis A cases, meaning that they essentially had a larger population that had known risk factors. And then we did implement a strike team approach to vaccinate at local county jails, community-based service locations, STD programs, and syringe service program sites. So our immunizations efforts in Indiana, so as of October 18th, over 200,000 adult doses of hepatitis A have been reported to our vaccine registry. This is including those administered as of January 1st, 2018. So about a year and a half of data so far. Historically, we only saw about 7,000 or so doses reported each year. So these are adult-only doses that are reported to our registry. So it doesn't include children and might not include some vaccines that weren't reported to our registry. About 25% of those doses, or over 50,000, were publicly funded doses that have been administered by local health departments, other state agencies, and the strike team, which is through the Indiana State Department of Health. And then the remaining 75% of doses have been administered with privately funded doses from physicians, pharmacies, and other entities. We've seen most of that 75% is from pharmacies. So a lot of people just seeking out preventive vaccination on their own, which is also great. So the strike team was an approach that we went with in Indiana as a self-contained unit of clinic managers, nurses, and data entry staff that have all the necessary supplies for a vaccination clinic of up to a couple 100,000 people. All of the supplies, vaccines, everything are available in the strike team van that you can see an example of. So we implemented that approach in 2018. The first clinics began in August of 2018. And we really wanted to assist local health departments by providing vaccination for the most at-risk populations at the locations that I've already listed before. And a lot of that work has ended up being in local county jails. I think it was Martha who said earlier that it just is a easier population because everyone is there already. You don't have to kind of seek them out. You just go to the jail. It is difficult to sometimes get people to want to get vaccinated, but it's a more contained group as long as you're able to work closely with the jail staff and get in there. So that's been a huge focus of our strike team. So outside of the jail, I just wanted to mention this. The strike team has conducted a total of 191 clinics in 72 counties in Indiana, at least 85 individual community clinics, like at places such as food pantries, soup kitchens, transitional living centers, homeless services, and at least 7 syringe service exchange programs or recovery centers. And a total of 9,132 doses have been administered just by the strike team as of October 25th. So jail clinics, particularly for the strike team conducted 105 individual clinics at local county jails. This does include going back to multiple jails or going back to jails multiple times, excuse me. And in those jails, the strike team alone has administered 5,780 doses to jail inmates. There have been some doses administered to jail staff and that sort of thing, but that number is just for those people who are incarcerated. And then, of course, local health departments have conducted many more post-exposure prophylaxis responses, as well as preventive vaccination clinic at local jails. We just don't have that data currently for each individual county, each individual jail outside of the strike team. So there's many other doses that have been administered in these locations by the local health department. And then some local county jails have purchased vaccine on their own, which is great. And then some have met standards to be able to hold public doses and administered vaccines in-house by having, regulated temperature monitoring and being able to help hold vaccine storage units. So the strike team in particular, I think this is mentioned before, education is very important when approaching all of these people at risk for hepatitis A vaccination. So there's a copy of the very quick and image-driven educational flyer that the strike team uses. So they provide some basic education on site on the day of each clinic, to all the jail inmates. This allows the inmates to make a decision on whether or not to receive vaccine that is informed and updated. Also identifies them as a high-risk population. And then it also allows them for questions to be answered by our nursing staff. We also recommend outside of the strike team that jail staff or local health department staff conduct similar education if they're going to do these clinics, but this is a part of the protocol for our strike team. In 2019, the ISDH expanded preventive vaccination efforts to the Indiana Department of Corrections facilities across the state. As of October 11th, over 12,000 doses had been shipped to IDOC, and over 9,000 doses had been administered in IDOC. We have had some responses to confirmed cases in IDOC, but fortunately have not identified any known outbreaks, known or suspected outbreaks. So most of these doses, vast majority, are just for prevention. And they have implemented a vaccination on intake program that we feel has been very successful in preventing the spread in Department of Corrections facilities and prisons in Indiana. Just wanted to show a map that's used to track by our immunizations division. So this just shows all the individual counties in Indiana. The green indicates counties that have been completed by the strike team. So completed just means they've been there at least once. Hopefully they're doing more than one clinic. We are encouraging vaccination on intake still for pretty much all of our counties. The orange indicates where a local health department has taken the lead and been able to successfully do local jail clinics on their own. And then the blue just indicates places where both the local health department and the strike team has conducted vaccination clinics, either preventive or response. And I think that's all I have. So thank you so much.
Thank you so much, Nicole. That was great. And again, if anyone has any questions about anything that Nicole talked about, or Kevin or Martha, please write us the questions on the questions tab so we can use it in the Q&A. And next up, we are going to hear from Gary and Jane. Gary Howes and Jane Crow work at the Knox County Health Department, and they will be speaking together.
Okay, we should be live now. A little technical difficulty here. Good afternoon from Knox County. I'm Gary Howes, the practice manager.
And I'm Jane Crow, and I manage the viral hepatitis program here.
And we'll have a few fluff slides in the beginning. I apologize, but being the first fully accredited health department in Tennessee, we have to have these slides in our brief. So I'll go through them. But it is a nice dog. That's a Siberian Husky, I believe. And basically, this is the vaccinations in our jail populations. It says in Tennessee, we're concentrating on Knox County. Of course, every person, healthy person, that is our vision. And that's every person, to include our inmates and our less fortunate. We try to lead by example here in this county. We have a lot of strategic priorities. We want to facilitate community approach to better health and whatnot. We try to respond effectively to our community's public health issues, which is what brought us into this Hep A response in the first place. And we want to ensure the conditions in which every Knox County resident can be healthy. Okay, here we go. Now here's the meat and potatoes. Our target audience: Knox County Sheriff's Office operates 3 facilities. The detention facility is the primary facility we have done our outreach in for the jail population. It holds approximately 1,220 inmates a day, which of course is a little over capacity. I think all of our jails nationwide are. And there's a total of 1,500 inmates on the average in our 3 facilities here in the county. The average stay is 26 days. So as mentioned earlier, we are getting a turnover, but we do have a captive audience, so to speak. Excuse me. To date, since July 16th of 18, which was when we started our first jail outreach, we conducted 75 outreach or outbreak events in the 3 Knox County facilities. Of course, the majority were held at the main detention facility. I was just out there yesterday doing some administrative duties, as a matter of fact. We're out there quite a bit. We have administered over 2,600 doses of the vaccine in our 3 facilities. We've encountered over 2,000 inmates that we've previously vaccinated or someone has previously vaccinated. We have had a total of 578 no's. We track this data for our purposes here. And Jane, you want to speak to this next bullet because this is a really positive.
Certainly. So as the CDC presenter mentioned earlier, we see a lot of co-infections with hepatitis A, B, and C, unfortunately, with this outbreak. So one of the benefits of us working in our local jails with the Hep A outbreak is we can address hepatitis B and C as well. So we've been able to refer 100 hepatitis C positive inmates to our hepatitis C program here at the health department so that we can do confirmatory testing and link them to primary care or specialty care to get their Hep C taken care of.
Now, to start with how we did it, I want to set the stage of where we were. And we felt that we needed to strengthen our relationship with our senior detention facility staff, both on the corrections and medical side of the house. We had been meeting quarterly with them to discuss our mutual interests and whatnot, but we really wanted to strengthen that, reinforce that, and to have a good team effort. We were conducting we still are, a monthly 2-day family planning clinic at our main detention facility in the female building. As a matter of note, we have the largest female inmate population in Tennessee from the county jail perspective. Unfortunately, that's our claim to fame. And we were already also seeing inmates that have been diagnosed with HIV in our COE clinic, our Centers of Excellence as our HIV clinic. We run the East Tennessee HIV clinic for this part of the state. And inmates are brought here to meet with our infectious disease physician to get their treatment started.
And we were also going in and counseling and connecting to care upon release hepatitis C positive inmates because a lot of our hepatitis C positives would end up incarcerated. And we would, although our jails don't test for Hep C, we would go to the facility and do the post-test counseling and linkage to care services. So we had already begun doing that in 2016.
We were also treating the inmates with tuberculosis and coordinating care. They do not have a negative pressure cell at our facility yet, so they need to be transported out, but we work with them on that. Because we also run the East Tennessee Tuberculosis Clinic as well. That's for Knox County and the 15 counties that surround us, the eastern portion of the state. And we'd already been providing positive STI notifications to the inmates along with the CDC recommended treatment protocols to the medical staff and coordinating that effort through our state laboratories. Now our next steps, and this was after we established a much better rapport with the senior leadership and started meeting more often and figuring out the what's and the how's. We didn't have the luxury of a larger strike team. I wish we did, but we're a metro health department, which down here in Tennessee means we're county funded basically. So our mayor's paying for this we have a county mayor and a city mayor. I know it's weird, but it works for us. And we're paying for this basically out of Hyde or out of picking the pockets of various grants. So we put an RN and a clerk in our detention facility 2 days a week to administer the HAV vaccine to both inmates and staff. We've been very successful under both, I think. We've established a very good rapport across the board from the deck plates corrections officer through the corporals and sergeants and lieutenants and captains all the way up to the assistant chiefs and whatnot. We got to a point where by working with their pharmacists and their medical staff that we signed a memorandum of understanding permitting us to give state-funded vaccine to our detention facility medical for them to use as they saw fit, basically for their staff, for inmates, for what have you. We provided them with the Tennessee Immunization Program, vaccine management training, and got them certified to hold this vaccine on site. We even gave them a fridge, by the way. We instituted the mandate, or I'm sorry, I should not say we. The Knox County Sheriff's Office instituted the mandate that all members of the voluntary inmate workforce must receive the first dose of Hep A vaccine. We facilitated the doses. That was the sheriff and the facility commander's call. And they just did not want to risk, infections in the kitchen facilities and whatnot. And it's a voluntary program, so it didn't really violate anyone's rights. Either you took the shot and got in the workforce, or you didn't. We've also recently joined the Knox County Sheriff's Office community collaboration effort to reduce inmate recidivism. I never can pronounce that right. Sorry. We are active in many of their programs. We do health education out there. We provide birth certificates for the outside workforce. We do mentor in the housing unit for military veterans, and recently I've been asked to help mentor and teach in our GED program. We're trying to really get a good GED program kicked off in the jail. And we've continued our quarterly meetings, and we've expanded our staff participation on both sides of the house to make sure we're involving everyone that needs to be involved in these mutual efforts, and we get all the good ideas in one room at one time.
Yes, and talk a little bit about the road ahead. So we're going to continue our robust efforts to prevent hepatitis A at Knox County Detention Facility. We're continually looking for new funding streams, which would be a great dialogue at the end of the webinar if we have ideas for funding streams. And we want to place a nurse practitioner and a licensed practical nurse at the detention facility 1 day per week for family planning, in addition to the current 2-day-a-month clinic that we are already doing. We would like to explore the possibility of a health department case manager at the facility for harm reduction and connecting inmates to care upon release, as we are also struggling with the opioid epidemic, as you are in Indiana, Ohio, and many other states. We will continue to work closely with the detention facility on the inmate reentry program and explore the possibility of a detention facility physician or nurse practitioner testing and treating hepatitis C during incarceration and connecting inmates to care after release. So we're very excited about the possibility of hepatitis C being addressed more directly by our detention facility. So overall, we've been able to improve our relationship and move public health initiatives forward in the jail systems because of the outbreak, frankly. So it's sort of the silver lining that the outbreak has gotten us out into facilities and community settings that we wouldn't have otherwise been in, and has led to some great new programs where we can improve health of the community overall.
Just an overview real quick of what's been going on here in Tennessee and in particular Knox County. We've had 2,652 cases in Tennessee as of last week. And we're finding, like the rest of you are, I believe that, 57% were recreational drug users. Homelessness, 16%. We did have a 14% that reported jail exposure. I'm not sure why that's not getting out there. I noticed on a previous slide it didn't mention Tennessee, but 14% looked like to be a high number compared to the other states. And we have also 39% of our statewide hepatitis A cases are co-infected with hepatitis C. Now, to move into Knox County, we've had 149 cases as of last Friday, and our numbers are a little higher on recreational drug use. We're at 69%. We also differentiate between intravenous drug users at 41%. 39% of our cases are experiencing homelessness, and we've had 26 cases for a 19% that report jail exposure. So I think our numbers are a little bit higher than what I was seeing as far as jail exposure goes. We have administered, this is outside of our clinic. I did not include the numbers that have been administered inside the walls. This is outreach, outbreak efforts, 4,799 vaccines at 164 outreach, outbreak events. And like you all, we're going to the food pantries, we're going to the homeless shelters, we're just out there everywhere. We've even went so much as to get into sport utilities and go out to the streets and just find homeless people that are sitting on benches and hiding under bridges and whatnot. We've conducted a total of 110 Hep C referrals, including the 100 from jail. Our numbers, we're starting to hope to get a little bit of a herd immunity. We're not quite there, but we've encountered almost 2,300 people that were previously vaccinated by us or someone else. And we did get a little over 1,400 refusals to receive the vaccine. And this next slide's kind of hard to distinguish, but if you look at the middle right, that's Knox County in East Tennessee, and we are seeing somewhat of a decline right now in our area, and I think it's due to our robust outreach efforts. Jane, you want to add anything?
I would just add that, as I said earlier, I think there's a lot of opportunity in crisis, and we've been able to bond closer with our corrections and other organizations through this outbreak. And I think it's going to help us be more prepared for public health outbreaks and emergencies that could occur in the future, because we've tightened our community and we've tightened our processes, especially with corrections. So if we have a massive overdose outbreak or another disease outbreak, I think we're going to be more ready to address that than we would have been before this happened.
Yes, we have stood up an incident command structure here, both in Knox County and in the state of Tennessee, and we meet frequently. We send out twice a month situation reports, and we share our lessons learned. And I agree with Jane. We're really preparing ourselves for a potential future issue that could be worse than this. Thank you very much for your time.
Thank you so much, Gary and Jane. That was very interesting. And thank you to everyone else who has already presented. So we have heard from national level, from state level, and from local levels this morning, and from both sides of an outbreak, from before and prevention, and from during and doing an intervention in different populations, like in jail and prison. So thank you again to everyone so much for talking about your different programs. We are going to move into our question and answer portion now. So feel free at any point in the question and answer portion to chime in, presenters. And then for those of you who are participants, please feel free to use the chat tab on the right-hand side of your screen to send more questions or to participate in the discussion. So the first question we have for everyone is, where can we access your materials? I'm sure that's different for everyone. So for the presenters, if you want to chime in and let us know, or if you want to type it into the chat tab so everyone has access. That was a question.
Hi, this is Martha with CDC. So a lot of our materials can be found on our website, which I'll post in the chat box. And then there are a couple materials you'll have to email us for, and you can reach us at viral hepatitis outbreak at cdc.gov.
Martha, anyone else?
Hi, this is Nicole from Indiana. I added a link to our website, our outbreak website, which does have a lot of materials. And if there's anything specific that isn't on there, also please reach out to me. There was a question in the chat on the community-based service. Not really sure what the question meant. Oh, I think the community-based outreach services for our vaccination clinic. Sorry, I jumped into a new question. I will have to think about that. Sorry to interrupt.
Drop my email into the chat there, okay, if you need anything.
While we wait for Tanya and Nicole to figure out that community-based services question, we have a question for Martha. When will the CDC recommendations for the correctional setting be published? I know that those were getting worked on.
Sure, and I'll hand that over to Liesl Hagen, who's our subject matter expert for corrections.
Hi, thanks, Martha. Yes, so we're in an ongoing process to update our recommendations for corrections across hepatitis A, B, and C. And those may be coming out at different times. It may not be one consolidated document, but for Hep A in particular, the way that CDC issues guidelines around vaccination is through the Advisory Committee for Immunization Practices. And that is a group of people, of subject matter experts in all variety of disciplines that relate to vaccination, and also representatives from community and other health practitioning organizations throughout the country. And there's also an opportunity for public comment in those processes. And we recently have been putting together an updated hepatitis A vaccine policy statement through the ACIP. And corrections will be represented in that document, but there's not a specific recommendation to vaccinate in correctional settings. And the reason for that is that there honestly is not a lot of evidence in the literature right now. We did a systematic review of hepatitis A in corrections from spanning from the present back to basically the beginning of time when publications were out. And we only found less than 200 references, only about 25 of which were even relevant to correctional settings in the United States for hepatitis A. And unfortunately, very few of those references directly address the question of vaccinating within correctional populations. And so we did address the question of vaccination in correctional settings by saying that, of course, as many presenters said on this webinar today, that vaccinating within correctional settings is a vital part of a community-based approach to reducing outbreaks in the community. But we're also actively engaged in trying to get some data out there into the world of published studies where we can reference later on the next time we have the opportunity to take this question up. Hopefully there will be more evidence in their literature because of the work that many folks on this webinar are doing to document the presence of infection in correctional settings so that can support a recommendation through ACIP.
Thank you, Liesl. So you all heard it. If you have any data about your work, please publish it so the CDC can take it into account with their recommendations. Thanks again. So we do have another question here. It is from multiple people, but also specifically from Jane about funding streams. So for the presenters, what are some of the funding streams that you have used for your programs, and how did you apply for them or seek?
In Ohio, all our stuff was GRF to actually tax dollars that are on our budget. We did receive the vaccine specifically from Ohio Department of Health. Other than that, everything was self-funded for the prison system.
Hi, this is Jane in Tennessee. And we were the same in the sense that we get our vaccines from the Department of Health, publicly funded. And we were been able to fund our nurse and clerks in the jails through a private grant. But other than that, we also have been self-funded as well.
And this is Nicole from Indiana. Our immunizations for the most part have come through the 317 program, federally funded, and then our strike team and some other efforts were through state funds and our immunizations budget that comes through the state funding.
Thank you. If anyone else in the chat wants to share some of their funding streams, I know that could be helpful for other people who don't have those same resources for funding. Just for a sort of overall general picture from the presenters, what are some of the biggest lessons? I know you guys have mentioned some of the things that are your big takeaways, but what are some big lessons that you learned when you were forming teams and doing outreach and building rapport with all of the people in the correctional facility?
Thing involved with both public health and corrections on different sides of the fence there, and this is one of the best cooperative efforts I've seen in a draft like this. We've had other projects in the past we've worked on, but just the way that seeing for the state of Ohio how they worked with their prison system, and then the outreach or the inreach into the jails was amazing, and the way they could all be mobilized, and seeing the different programs in today's presentation, this gives me a lot of hope for people actually recognizing that correctional health care is public health, and I think we can build on this to say that maybe look at some other aspects of care.
Gary Hauser in Knox County. I'd like to echo that our corrections facilities, in this case our detention facilities, was crucial, and we were able to successfully get senior level buy-in, which facilitated the more junior level buy-in. As we all know, corrections officers are very tasked during their workday. There's always staffing issues. And the last thing a lot of them want is a bunch of public health nurses running around the pods trying to get in their way and making them transport prisoners. So it was a painful process, but through open communication and actually getting to know these folks at all levels, it really helped us.
And this is Nicole. I would echo what everyone else has said, but specifically just highlighting how difficult it can have these relationships already built in place, especially in Indiana. We, like Ohio, are a home rule state. So we have 92 different counties, 92 or so different jails and different sheriffs and different leadership, as well as local health departments that are all involved. So getting the message out that this is an issue and what people can do to prevent it is important, but then actually building the relationships and having those decision makers truly understand that the prevention part of it is so important. I think it was mentioned earlier also, but a lot of these facilities were so hesitant to do any prevention, and until they had really serious situations on their hand, weren't especially interested in talking with us or working with us. So I think just it kind of reminds us that we need to build these relationships and then keep it up once these outbreaks are over. And once even though we feel a lot of people are vaccinated in these populations, that the work isn't done.
Well, thank you all for sharing that. I know that the relationships with people who work in correctional facilities can be challenging. So if any of you have any materials, I know, Kevin, you mentioned that you all created some materials that you're frequently evaluating. So if you do have the ability to send those out as a reference guide, that would also be really helpful. We have another question coming in here, and it's, were the vaccinations discussed just for hepatitis A, or was the combo hepatitis A and hepatitis B vaccine used, the Twinrix?
Gary House here, and from speaking for on the Knox County, Tennessee, they do have strike teams that visit all 95 counties for Hep A and Hep B. We're broken down into regions, so roughly each jail gets a visit about every 8 to 10 weeks. But and it is a concentrated effort. We've actually teamed with them on a number of occasions and went in the jails together to minimize the strain on the correction staff.
This is Nicole. We mostly focused on just hepatitis A vaccine, multi-series required for the Twinrix, but do recommend Twinrix as a great option for inmates in jail settings. So we did focus only on hepatitis A vaccine, but do recognize the potential and helpfulness of Twinrix.
Hi, this is Martha with CDC. I was just going to mention that what Nicole just mentioned, we hear that a lot from many states. I think in the context of outbreak response, hepatitis A vaccine is the more frequent one used because these are very transient populations, and there's a lot of question about whether you'll be able to follow up again for subsequent doses for Twinrix. And just a reminder for everyone that Twinrix can be used for pre-exposure prophylaxis, but is not recommended for post-exposure prophylaxis for hepatitis A.
Thank you for sharing that, Martha, and thank you for clarifying. Then does anyone else have anything to share about their use of monovalent versus Twinrix?
Sorry, this is Nicole again. I wanted to add that as a side to some of the initial work, very closely at Scott County, Indiana, which I'm sure most of you know was kind of well known for its HIV outbreak in 2015. And resources after that outbreak included very routine administration of Twinrix for Hep A and Hep B. And we feel very strongly that that preventive vaccination really made the at-risk people in that county not get hepatitis A, essentially. We saw way fewer cases, I think fewer than 10 or 15 total for that county, which was surrounded by all of our outbreak counties initially for our Indiana outbreak. So that's a really big success story that we were trying to look into a little more closely. But so while we didn't do that for our Hep A response, we feel that that's a truly successful public health prevention effort that we identified for that county.
Thank you, Nicole. That's really helpful. We have one more question, and then I think we'll have to wrap up soon. But one of the questions was, in the correctional settings, do you all charge co-pays to people who are seeking hepatitis A related medical visits?
Not in Knox County, no.
In outbreak situations, we don't charge copay. Sorry if you did hear that. In Ohio, during outbreak situations, we don't charge copay.
All right. Well, thank you again, everyone, so much for sharing. If anyone has any more last minute quick questions, feel free to type them into the questions or the chat tab. We have heard so much amazing information, such great practical examples from all across the United States in different settings. And we just want to thank all the presenters again for taking your time, sharing your tools, and giving everyone on the webinar today lots of insight into how to address hepatitis A. Also, thank you everyone who was able to make it into the webinar today. We appreciate your thoughtful questions and your participation as well. We will be posting the video recording of this whole webinar onto our website afterward. We will also be sending out materials and links and email addresses for people who want to get in touch with any of the presenters from today. If you have any other resources you'd like to share or you'd like us to post or send out, please email them to us or send them in our chat right now. And then just one final plug for the National Hepatitis Corrections Network. We do host an annual meeting in the spring every year, and this year's meeting is March 31st and April 1st in Raleigh. It is right before the ACCJH Academic Health Policy Consortium on Correctional Health. Sorry, that is a hard acronym for me. But the NHCN annual meeting provides a unique networking and collaborative space for people working in corrections and public health to discuss viral hepatitis testing, treatment, education, and linkage to care in the correctional custody settings. So if you are interested in attending our meeting, let us know now, or please feel free to email us at thecorrectionsnetwork@gmail.com or to email the director of the NHCN, Mandy Altman, at mandy@hepeducation.org. Or if you want to learn more about the meeting or the NHCN in general, you can visit our website at hcvinprison.org.